Good afternoon, everyone. My name is Angela Dieter. I am the director of our Office of Harm Reduction over at the Erie County Department of Health. Welcome to our monthly Bridge Erie Learning Collaborative. Today, our guest speaker is Maria. She goes by Apple Domingo, serves as Director of Veterans Affairs at the Veterans One Stop Center. She brings a deep commitment to supporting those who have served. With a degree in behavioral science and over 30 years of experience in the nonprofit sector, Apple has cultivated expertise in working with diverse populations. Her background includes 12 years in refugee resettlement and 18 years in adult education, which she now channels into comprehensive support services focused on homelessness prevention and suicide prevention for veterans. Known for her compassionate leadership and strategic vision, Apple is dedicated to empowering veterans and fostering resilience in the community. Welcome, Apple, and you're welcome to take it away.
Thank you, everyone. First, I'd like to thank everyone for inviting us to present it today. This is wonderful. We get to kind of showcase who we are and get to know everyone from your department. Before I proceed, I just want to know if anybody wants to talk more, please don't hesitate to email us. We are working through partnerships and collaborative with the entire Buffalo, Erie, and Niagara community. So if there's any way we could collaborate, we are very much open to it. Okay. So VOC, Veterans One Stop Center. This is who we are. We have two kind of grants that fall under harm reduction, but the big one we have is the Sergeant Gordon Fox Suicide Prevention Grant Program and the SSVF, Supportive Services for Veteran Families. This is the homeless prevention programming. So I apologize, I have the sniffles, so you'll see me kind of sniffle here and there. But what we do promote is housing stability and then overall health and well-being. So part of that is harm reduction, right? To have the overall health and well-being of the vets, we have to really look at everything, including health. Okay? So we have the approach is built into two of those programs. Like I said, it's built into SSVF and it's built into the Fox prevention program. So what we do is we integrate those services while prioritizing safety, dignity, and empowerment. Most of our programs are low barrier. So especially the housing program, we won't require you to, for example, be sober in order to receive the services, but we will address those type of things while you are working with us, if that makes sense to everyone. The Fox program is very prescriptive. We really have to do harm reduction, lethal means safety programming through Fox. That's part of our 10 core services, which includes community education. Okay. So what are our services? So there's through those two programs, we have what we call a healthcare navigator. So our healthcare navigator provides the services if you are enrolled on those two programs. So part of that is overdose protection, safe use and hygiene education, peer recovery support, crisis intervention, and then access to treatment referrals. So we have community partners that can do that, including the VA, and coordination with all of the health providers in the area. While we might not have a direct referral system, we do have them in our resource list to make sure that we are comprehensive because we do serve 12 counties. Okay? The healthcare navigation, these are three of the partners that are already established with us through healthcare navigation. So we actually have the Matters Network. I don't know if you guys have heard about Matters. It is a direct referral to people for substance. We partner with them and they can give, one of the things that we like about them is they would provide transportation to our veterans if need be. And it's no cost to the veterans. They provide us with a book, a MacBook, so we can just open that referral and refer them right away. They will test and, oh, okay, I'm so sorry. It doesn't change slides. Okay, we tested this earlier and it seemed to work. I apologize. Give me a few minutes. Let me see if putting them, hang on 1 second. I will stop share. Give me a second. Can everybody see that now? Is it advancing now?
We can, but you're gonna also want to put it into presentation mode. I think that might help with the slides progressing.
I think that's what I did. When I put it in presentation mode, it stopped doing that. So I had to go back here. But let's see from current slide. Can you see them now? Is it
Yes,
advancing for you?
we do. What we see on our side is that it is the harm reduction services slide.
Okay, I'm going to move it forward to, all right, move forward. Okay, it's not moving for me. So sorry.
Let me see.
Okay, does it move now to about VOC?
We're still on the harm reduction slides. I'm gonna see if sharing my screen will be helpful.
Okay, so I think that's what happens when I share the slide. It actually doesn't move on your end. But if I just leave it here in PowerPoint, you can see me move it, right?
Yeah. So I'm
Okay,
gonna would it be helpful if I took over this portion and shared the slides for you?
that would be wonderful. Thank you so
Okay.
much.
I'm happy to do that.
Stop sharing.
So you want to be here?
We should be on the services, matters, VOC's harm reduction services. So you're seeing the overdose prevention, safe use and hygiene, peer recovery, and crisis intervention.
So that's which
Slide.
It
is
was the one that was saluting.
okay.
Actually, I'm sorry. Could you move to slide 5, which is the partners?
Yep, that's where I thought we were. Okay.
Okay, perfect. Are we good?
If Apple, if you're able to see the screen where the slides are, yes, the slides are shared with everybody.
Yes. Okay, sounds good. Thank you so much. Okay, so these are, like I said, direct programs that we're working with. We also work with the VA domiciliary at Bath, where we would refer people if necessary. Some of our veterans um, would want it by themselves, like they would request for the service, but we have that referral for the DOM. What is good with these, and then we also have Freedom Village through Horizon Health Services, where they can stay for substance abuse and stuff like that. And what we normally do with all of them is that when they're exiting the DOM or Freedom Village and they need homeless prevention and suicide prevention, then they get re-referred back to us, if that makes sense to everyone. Okay, can we, next slide, please? All right. So integration with Fox, suicide prevention program, and SSVF. What we have found is that people who are homeless also tend to exhibit suicidal behaviors. And part of what we need to do is assess their health. Why aren't they able to pay their rent? And most of the time, it's because there is that alcohol, substance abuse, and everything involved. And so they would use their VA benefits and then end up on the street, if that makes sense. So by integrating these two programs, the suicide prevention program, can you go back, please? Sorry. Thank you. So by integrating these two programs, we really reduce barriers at both junctions. So if we engage with them under the FOX program, we will look for those barriers. If we engage with them under SSVF, we will do the same. And then they are cross-referred to our programs, which means that they're going to get health navigation. So the services that we had discussed earlier meant that they're getting that through those programs. So wherever they enter, they will get that health navigation. And then when they're in crisis and they can see that we are helping them, it kind of builds trust a little bit to say that, you know, we didn't come here for this, but you recognize the need for help and support and you gave it to us. So when we support the recovery, we are then able to address the housing and maybe improve their income needs. Does that make sense? Because most of the time, the reason why they're homeless is because they're not paying rent, and the reason why they're not paying rent is because they're using it for their vices, if that makes sense. Okay. Next slide, please. Okay. So like I said, we do collaborate with community partners. We are not the clinical provider for all of the support and the help that we do. However, if it lands on our desk, we will collaborate with providers and local agencies to make sure that we're not brushing that problem off, right? We're just not saying, oh, we don't help you with that, so we're not going to address it. So we'd love to collaborate, partner with community partners and service providers. What we want to do is make sure that we expand access to harm reduction resources for the veteran, and we facilitate cross referrals for care. And we also are proponent for not reinventing the wheel. So if there is best practices, we are well and willing to adopt it to make sure that both agencies, both providers are getting what they need for data and for improved outcomes. Substance abuse disorder is recognized as a risk factor for suicidal behaviors. So really, we need to address those risks, such as opioid use, as part of our strategy in order to address the suicidal ideation, if that makes sense. So really, the strong collaboration with other programs helps us with that. In fact, one of our core service in the Fox Suicide Prevention Program is to refer out to any services and any emergent needs, including emergency assistance, to our veterans when they're experiencing any type of health emergency, including substance use disorder. Does that make sense? Okay. Next slide, please. Under the FOX program, these are the specific interventions that we provide through the FOX program. So we have lethal means safety and secure storage. So we can, through FOX, pay for expenses associated with lethal means safety, unlocks, medication storage, or anything of that sort. So we always assess for that, and we educate families on lethal means safety, on safe talk, and on firearm storage. So that is required through the grant. And sometimes residually, we will see some substance abuse when we're doing when we're doing lethal means. sometimes part of the reason why they are unable to coherently participate in their stability plan is because of substance use, if that makes sense. So then substance use reduction is part of our specific intervention, if that makes sense. We got to link them to treatment. If the baseline mental health, we provide baseline mental health screening. And if it says there is a very high risk of suicide due to the mental, the behavioral, and the substance use, then we must refer the eligible individual first to VA because we are funded with VA. But if that veteran says, no, I don't want to go to VA, we have to refer them to community services, and we do. Okay? It can never be like it's there and you don't refer. We have to make that referral. So we do employ case managers and healthcare navigators, like I said. And what we normally want to do is provide a warm handoff. Sometimes the veterans would say, no, I don't want you to do that. And we, because of confidentiality, or they want to do that on their own, we will respect that. But really, the rule of thumb is to do warm handoff. So the more we have contact with services in a point of contact from the services around the community, the better the warm handoffs are. But we would respect if a veteran says, I'll do that myself. That makes sense? Okay. Part of that intervention, once we have the safety, the substance use reduction, is peer support. So we provide peer support services here in Veterans One Stop, and some of them have lived experiences, some of them don't. But the idea is to have a peer and not a trained professional kind of collaborate with the vet. Most of them would need to establish that trust, and there's a automatic camaraderie that's built in from people who serve that cannot be replicated if you did not serve. So having that peer support programming with us, we are not we're not going to mandate what they need to do, but they're there to kind of listen and look at changes in behavior and things like that and bring it up to the surface when they see it. But most of our peer support are in, if you go to our website, you'll see some events, and most of the peer support is kind of hiding under those events. I don't want to say hiding, but we provide that platform through fun. And sometimes people will go to all events and then all of a sudden stop going. So the peer support are the first people to kind of recognize that and then refer to the case managers, and then, you know, peer to peer, be like, are you okay? Why are you not participating? You know, and so on and so forth. But those specialists kind of serve a role and model for our veteran participants, so they can be almost like their mentor without strings attached, if that makes sense. Like, it's not like a mentor that you have to see every day, that you're required to see every day. We kind of put this in a relationship type base where a peer and a veteran would organically develop that relationship through fun, through events. Like, we have events like scuba diving, breakfast, dinners, arts therapy, and things like that, that kind of gets them into the building and gets them, get the veteran to engage in another veteran and in our peer support specialist, if that makes sense. Sorry, I stutter a little bit, but next slide, please. So outcomes and impact, that coordination of everything from our program, from peer support to suicide prevention to homeless prevention, really increase veteran engagement in services. And the hopes, the impact that we want to do is reduce overdose incidents among participants. Of course, when that happens, the outcomes for recovery, for housing stability, and for suicide prevention also goes up. But again, we want to be able to strengthen partnership with healthcare and outreach networks. I want to tell you guys the story while we're here in Outcomes and Impact. We had one veteran that came to our organization. He was homeless, and he was here with his father and uncle. So they were telling him to come to us and to avail of our services. So he came in day one, and we were going to enroll him. He was supposed to come back the following day, to give us the paperwork to finish enrollment, and he overdosed, right? So our engagement was sort of like not there yet, and it was very heartbreaking. But what happened then is the father and the uncle would hang out here. We do have a third floor where vets can just hang out for that isolation factor. But he would just hang out here, and he would say, this is my happy place because this is the last place I saw my son." And in turn, he enrolled in our Fox suicide prevention program, and so on and so forth. So it kind of shows you, I mean, that the outcome is not what we want, but recognize that that engagement sometimes becomes a safe space for the loved ones here at Veterans One Stop. Okay. Next slide, please. Like everyone, we do have challenges, right? Stigma surrounding substance abuse is really big, and just military culture, people don't always reveal this to us, right? Because in the military, you don't want to show your weaknesses. So many veterans do not want to receive the services because they don't want the stigma attached to it. So a lot of times, they will come forward. And sometimes we already know, we suspect it, but so the stigma is still big with mental health and substance use for veterans. It's just something in a military culture that, have been embedded in them, like suck it up, just continue on, chug on, don't complain, and so on and so forth. So most of the time they self-medicate if they have PTSD, and most of them go to substance use. So this is still something that we're battling, and I don't know how long it's going to take for the stigma to go away, but slowly and surely, I think we're chipping on the block, especially because part of the PTSD, the substance use, and all of that are being recognized by the VA, and sometimes if we can get them their claims for benefits through the diagnosis, increase their service connection disability, then it helps them come forward. But we're still not there. So I know you all know this. I'm preaching to the choir, but I just want to make sure that you know that it's a higher level of stigma when veterans are involved. Okay. Next slide, please. Okay, so what do we hope to happen? What is our call to action? We'd love to have more referrals. We'd love to loop in more partners and maybe conduct some joint harm reduction trainings between our population and everyone else, including vet families. I don't know if there's room to advocate for funding and policy alignment, but we're open to all of these possible calls to action. Again, my name is Domingo. I work for Veterans One Stop. I am the Director of Veteran Services. My email, you can get me through mdomingo or adomingo. It'll come to me at vocwny.org. Just really quick, before I end, I wanted to show you in the next slide some of the, sorry. Okay. I just want to make sure that you know our website is www.voc.ny.org. You can move on to the next slide. I apologize. There you can actually see all of the events that we are talking about. The big one right now for veterans is the skydive. Lake Placid trip. And any veterans, even if they're enrolled in our program or not, any of the events at the website, people can just refer a veteran, or the veteran can sign up for themselves, and then they're now engaged in our peer support. Does that make sense? All right, I am open for questions, you guys.
Thank you so much, Apple. I haven't seen any questions posted in the chat while you were speaking, but we can give folks a couple minutes if there's any last minute things folks are thinking about while we transition over to Jason. And Apple, if there's any resources you want folks to have direct access to, if you want to send those over to me, they will be sent over in the newsletter to folks after we are done here. So it'll be like the following week, folks can have access to any sort of resources or anything like that that you'd want folks to know about.
Thank you. Thank you, guys. Thank you again for having me. I'm gonna apologize and I'm gonna hop off because I have another one scheduled at 1 o'clock. So I apologize, but that I couldn't stay. But yes, I will send them all to you. Thank you
Yeah,
again.
no need to
Thanks,
apologize.
Apple.
Thank you so much for your time today.
No problem. Thanks. Bye.
Bye-bye.
Bye.
All right. Well, that was a really great presentation by Apple with the Veterans One Stop Center. Can everyone hear me okay, first of all?
Yeah, you sound great, Jason.
Sounds good.
Great. And let me just do a quick test of advancing the slide. Yeah. The slides changed for everybody? Yeah.
Yes, we are right there with you.
Okay, great. Welcome to Bridge Erie for the overdose data updates for November 2025. A brief overview of what we're going to be covering. We'll look at the total overdose deaths in Erie County. We're going to compare that to statewide trends. We're going to look at the overdose death demographics, then the toxicology, then some demographic trends within the toxicology of overdose death. We'll look at locations of overdose by zip code, and we'll move into non-fatal, report frequency and location, and then we'll compare the zip codes of non-fatal and fatal overdoses. So as of the most recent data available from November 7th, 2025, we have a total of 216 overdose deaths in Erie County, 154 of which are suspected opioid related, 123 are confirmed, and 31 are waiting for toxicology. Another 62 have been confirmed non-opioid related. So still exhibiting a downtrend, and we are likely to come in at probably under 250 overdose deaths for the year. When we look at statewide trends, the most recent data available is through April 2025, with the last update being posted in September. So this is the same as we were looking at the last Bridge Erie. At that point in the year, as of April, Erie County had exhibited a 29% decrease year over year, from 36 deaths per month to 25 deaths per month on average. And at that same point, New York State had exhibited a 37% decrease. But as of October 2025, since we have some more recent data here, we can see that we have caught up to the statewide trend. Erie County is now at a 38% decrease in monthly deaths year over year, an average of 21 deaths per month over the past 21 months. And we have been in continuous decline since mid-2024, although we do show some signs of that slowing down a little bit. So we'll continue to monitor that. And once the state data gets updated, it'll be interesting to compare our recent data to the statewide data once that's updated. For overdose death demographics, we can see that the Black population in Erie County is disproportionately affected by overdose deaths. The orange bar here is the percentage of overdose deaths by race for the period of August 2023 through July 2024. And that was where the peak of the disparity was during that time period, where our overdose deaths were approximately 35% Black compared to their representation in the population being roughly 13%. The red bars are overdose deaths in our most recent available data from November 2024 through October 2025, the past 12 months. And we can see that among those overdoses, there were 22.7% Black. So we can see that the disparity is beginning to close among the Black population, which is a good sign, and we hope to see that continue. Other demographics, aside from Black and white, do not contribute very much to the overall overdose death picture. There are very few of them. But from the data we have, the Asian population is underrepresented among overdose deaths relative to population, and the Native American, American Indian population is overrepresented relative to population. Now we're going to look at those demographics in a little more detail with a population adjusted graph. Population adjustment allows us to more clearly see disparities and allows us to see them develop over time. And it basically shows which groups are most disproportionately affected. So it controls for the population size of each group. And here we are looking at Black, white, Hispanic ethnicity, and other race categories are excluded due to the limited amount of data. So the bigger the gap is between these lines, the bigger the disparity is. And we can see that the disparity was the largest in mid-2024, and it has been closing rapidly. In recent months, we are seeing roughly equal death rates in the Black and Hispanic population, and both are significantly higher than among the white population. So the disparity still exists and is significant, but it has decreased significantly, and between Black and Hispanic populations, it has been eliminated almost entirely. Looking at year over year, we see 12 months ago, October 24, on this graph, the Black overdose population adjusted death decreased by 54%. In the Hispanic population, we saw a 31% decrease. And in the white population, we saw a 20% decrease. And again, other categories are excluded due to limited data. So we're continuing to see gains across the board when it comes to overdose deaths. Now, this is something new we're doing here. We're looking specifically at the opioid-related overdose deaths as opposed to all the overdose deaths. So among the opioid-related deaths relative to overall overdose deaths, the disparities are actually closing even faster for the Black population. So the Hispanic population is now the most affected by opioid overdoses compared to other groups. So we'll continue to monitor that and see how that develops. In July 2024 is when we started to see this sharp decline in Black population adjusted deaths. And in January 2025 is when we saw those lines cross over and the Black opioid-related deaths drop below the Hispanic opioid-related deaths. This is showing the tail end of those two graphs side by side, so you can see more clearly the demographic trends in all overdose deaths versus opioid-related deaths. And we can see that the disproportionate impacts on the Black population is decreasing far more rapidly for opioid-related deaths as opposed to all overdoses. But we do see significant gains across the board in all groups. So for all demographics, opioid-related deaths are decreasing faster than overdose deaths as a whole. So now we're going to look at non-opioid deaths. So unlike opioid-related deaths, the racial disparities among non-opioid deaths remain quite large. Unfortunately, Hispanic data had to be excluded from this analysis due to limited data. Non-opioid deaths only constitute about 20 to 25% of our overdoses, and with the limited Hispanic population, we just did not have enough data to include that here. So we can see that in July 2022, mid-2022, non-opioid deaths among the Black population began to increase, peaking in mid-2024 and then pulling back somewhat, but remaining elevated. And we did not see that decrease in disparity like we see with opioid-related deaths. So this is a very notable and stark trend between the opioid and non-opioid deaths. Now we'll look at age. So the 40 to 49 age group is still the most disproportionately affected by overall overdose deaths. And the decreases in death rates that we've seen across the board do appear to be slowing. Among the 50 to 59 and 30 to 39 age groups, we stopped seeing that continuous decline. But for their in age 40 to 49, it's remaining relatively stagnant. Same with age 60 and older, and age 29 and younger is decreasing further, despite it already being at a very low rate, decreased even more. Now looking at opioid-related deaths, we can see more dramatic declines among the 30 to 39 and 50 to 59 age groups, decreasing even faster than for overall overdose deaths. And ages 40 to 49 are still most affected despite significant decline. So for the 40 to 49 age group, we're seeing more decline among opioid-related overdose deaths as opposed to overall overdose deaths. Here's those lines side by side again. So we can see that for opioid-related deaths, disparities by age group across the board are closing more rapidly for opioid-related deaths compared to all overdose deaths. So we can see that the gaps between the lines for opioid-related deaths are much smaller. And we also see more precipitous declines in all of these age groups compared to all overdose deaths. For non-opioid deaths by age group, ages 29 and younger had to be excluded due to limited data. But we actually see a different demographic that's most affected, and that is people in their 50s, ages 50 to 59. This demographic increased throughout 2024 and has flattened out in recent months. But yes, they are the most affected demographic of non-opioid deaths. Ages 60 and older saw a significant decrease beginning around November 2024. And that's really the only group where we've seen a significant decrease in non-opioid related deaths. Among 30 to 39-year-olds, it's decreased somewhat. 40 to 49, it's been fairly constant for the past couple of years. And we've seen that increase in the 50 to 59 demographics. Now looking at toxicology, here we're comparing the most recent 12 months on the right to overdose deaths in 2023. 2023 was where we saw our peak of overall overdose deaths and also the peak of our deaths related to both opioids and cocaine. So compared to 2023, in the past 12 months, deaths related to opioids and cocaine fell to 37% from a high of 58%. Conversely, we see cocaine without the presence of opioids rise to 22%, up from 13% in 2023. Interesting to note that overall number of cocaine deaths without opioids is roughly the same, 55 versus 52, but it is now a much bigger portion of the pie, considering other categories have decreased pretty substantially. Now we're going to look at this pie chart over time. So if the pie chart is like a snapshot, this line chart shows how each slice changes over time. And so that most recent 12 months is indicated by this window here of the past 12 months. This allows us to see recent trends more clearly, and each point is an average percentage over the past 6 months. So it's how many overdoses in the past 6 months by percentage we are seeing. So the most recent data point we saw a simultaneous slight decrease in deaths related to both opioids and cocaine, and a slight increase in deaths related to opioids without cocaine. That decrease in opioids and cocaine was a bit of a reversal after several months of increase. That was something we were monitoring to see if we were going to be returning to trends we saw in 2023 of higher opioids and cocaine deaths. But it seems like after rising somewhat, it came back down. So currently we're seeing about one third of our deaths related to both opioids and cocaine, 1/3 related to opioids without presence of cocaine, 20% related to cocaine without opioids, and 12% related to other substances. So it was August 2024 that we really started to see that decline in deaths related to opioids and cocaine, and an increase in deaths related to cocaine without opioids. So those trends started around the same time in August 2024. Now we'll look at some demographic trends within toxicology. So this chart is looking at among cocaine deaths in the absence of fentanyl by race, what percentage of deaths in that demographic were related to cocaine. So we can see that in mid-2024, we saw a sharp increase among the Black population in the percentage of Black overdose deaths that were related to cocaine without opioids. We saw a stark and sustained increase to now we're about 40%, 35-40% of the Black population's overdose deaths are related to cocaine in the absence of fentanyl. Prior to that, we saw closer to 15-25% of the Black population's overdose deaths being cocaine in the absence of fentanyl. Conversely, we did not see that same stark and sustained increase among the white population. We see it somewhat, but it's not as consistent or as stark. So definitely a notable shift that occurred there. So now looking at cocaine deaths in the absence of fentanyl by age, we see another trend of note is that cocaine deaths in the absence of fentanyl are mostly age 50 and older. In all but 2 quarters from 2022 through quarter 2 of 2025, at least 50% of those overdoses were age 50 and older, and sometimes as high as 80 or 90%. So definitely a very significant difference in age demographic there. Now we'll look at overdose deaths by zip code over the past 6 months. So May 2025, through October 2025. And this is showing all zip codes that had at least 5 overdose deaths in this time period. The zip code with the highest number of deaths was 14215, which is on the east side bordering Cheektowaga. We saw 8 deaths there. 14201 is the lower west side near Allentown, in the city of Buffalo. That saw 7 deaths. We also saw 7 deaths in West Seneca, 14224, which is unusually high. 6 deaths in 14212, which is the east side near Broadway. 14220 in South Buffalo, we also saw 6 deaths. And then we saw 5 deaths each in 14211, 14216, and 14206. 14216 in North Buffalo is a relatively new addition to the list. We are seeing a disproportionate amount of deaths in North Buffalo compared to what we had seen in the past. So that's a new addition to the list. Now looking at where things have changed versus in the most current 6 months versus the previous 6 months, the areas where we see increasing overdose deaths are 14215, 14212, 14216, which is that North Buffalo zip code, 14220, West Seneca, and Hamburg. And areas that we see decreasing overdose deaths are 14211, which is near Genesee Street on the east side, 14201, again, the lower west side, Tonawanda, and also 14206, which is the Lovejoy area. Now moving on to non-fatal overdose reports. So here's the 30-day average of non-fatal overdose reports per day from 2022 to the present. Our office receives overdose reports daily from HIDA. These are aggregated from law enforcement reports and emergency service calls, and these are used for follow-up after overdose and also outreach planning. It's important to note that not all overdoses are reported. There's a significant degree of underreporting, because a lot of overdoses are handled by individuals without being reported to law enforcement or emergency services. But we use the reported overdoses as kind of a proxy for overall overdose activity. So we typically see between 2 and 3 non-fatal reports per day. And so despite the fact that OD deaths are down, we do see non-fatal reports remain relatively steady. Through September and October, we saw the non-fatal reports per day creep towards the top of our typical range of about 3 reports per day. Then they started to come down, went up a little bit, and now are sitting around 2.2 reports per day. So it's been fairly constant for quite some time, despite the consistent decline in overdose deaths. In terms of location, the areas that we see increased reports in are Black Rock, Grant Ferry, and the Lower West Side predominantly. Those are 3 of our consistently highest areas for non-fatal overdose reports. Lovejoy 14206, which is interesting because Lovejoy is one of the areas where we saw decreasing overdose deaths. We saw increasing non-fatal reporting. 14211 and 14215, which are both on the east side. 14220, which is in South Buffalo. 14216 in North Buffalo, West Seneca, Springville, and also Eggertsville 14226 within Amherst. Areas where we saw decreased non-fatal reporting included Broadway 14212, Hamburg 14075, Williamsville 14209, which is kind of in the center of the city of Buffalo, mostly along Main Street, and 14072, which is Grand Island. So now we're going to compare overdose deaths against our non-fatal reporting. We typically see more non-fatal overdose reports than overdose deaths in each zip code. If we see overdose deaths exceed non-fatal reports, that is cause for concern because it's a potential indicator of underreporting of non-fatal overdoses. So that's something we monitor. So where are we seeing more deaths than we would expect relative to the non-fatal reporting? The east side, 14215 and 14212. West Seneca very significantly, and also Hamburg quite significantly. So those areas are high concern where there might be a lot more underreporting of non-fatal overdoses than we see elsewhere. So those are high areas of concern. Moderate areas of moderate concern include 14216, which is North Buffalo. Again, we saw an increase in overdose deaths more than we would otherwise expect. We didn't really see too much of a corresponding increase in non-fatal overdose reports. We also saw a decrease. Saw more deaths than expected on the east side near Genesee Street, which is 14211, and also in South Buffalo. So in summary, overdose deaths continue to decline, but non-fatal reports remain relatively steady. Disparities by race and ethnicity are still significant, but decreasing. They do remain large for non-opioid related deaths. And opioid-related overdose deaths now have the most disproportionate impact on the Hispanic population as opposed to the Black population. The age profile of death appears to differ by substance. Non-opioid deaths are predominantly age 50 to 59, and opioid-related deaths are predominantly 40 to 49. So we'll see if those trends continue. We see high concentrations of death in 14215, which is the east side of Buffalo, 14201, which is the lower west side, and 14224, which is West Seneca. We see decreasing overdose deaths in 14150, which is Tonawanda, the lower west side, 14206, which is Lovejoy, and 14211, which is the east side again. And you might be a little confused why overdose deaths are decreasing in 14201, but they're listed as high concentration. And that just goes to show how persistently we see overdose deaths in that area. That even though they've gone down, they're still one of the highest concentrations of overdose deaths in 14201. In terms of having more deaths than we would otherwise expect, West Seneca and Hamburg, we've really seen light up recently with more deaths and not a whole lot of non-fatal reporting going on. And also on the east side of Buffalo, 14215 and 14210. Once again, 14216, which is North Buffalo, is emerging as an area of concern. So we'll be keeping an eye on that in terms of overdose deaths and non-fatal reporting. So thank you very much, everybody. We're wrapping up here. If you're interested in looking more specifically at where overdose death or overdose reports are occurring, we host a quarterly webinar for community organizations where we show heat maps of our overdose reports. People can ask questions, request specific maps, discuss what they see in the field. And you can also sign up after attending at least one for monthly heat map updates. We have an MOU that you can sign and return that just indicates that you won't disseminate this information outside of your organization. And then you'll be added to a list to receive our monthly overdose updates, heat map updates. The next webinar is on February 23rd. And that QR code will take you to this form. I will post the link in the chat afterwards if that is easier. So we encourage people to attend that. We'd love to get some more people on that distribution list. And that's it. Do we have any questions or comments?
Thanks, Jason.
Yeah, thanks. I don't see any in the chat, but we can give folks a couple minutes if there's any lingering questions that may pop up.
Great, then I'll drop the link. Oh, someone has a hand raised.
Kenneth, did you have
a
question?
Yeah.
I was trying to get you unmuted. Oh, put it in the chat.
Oh yes, you're good. You're good. We have your form. We got you the first update out to you. Yeah, you're good. You'll keep receiving those monthly updates.
Thank you, Kenneth. Well, I think we are all set, guys. Thank you, everyone.
Thanks, everyone.
Yes, thank you,
Looking
everyone.
forward.
Oh, hold on. All right, we got a request for some collaboration.
Yeah, Rayshawn, we will definitely reach out to you. I know that we are looking forward to having you present with us in the coming months, and we'll definitely be in touch. Thank you for all that you do.
Thank you for coming, everybody.